Welcome to Session 3 of Foundations of Global Health. In Session 3, we're going to talk about ethics and human rights. Specifically, how human rights is very important to global health and how actually global health and human rights are interconnected. So, where does our conceptualization of health as a right or global health as a right come from? Well, it comes simply from the World Health Organization or WHO Constitution, which defines health as a right. Here in the second tenet, which basically says the enjoyment of the highest attainable standard of health is one of the fundamental rights of every human being, is the first actual declaration of health being an actual right, or basically a human right. And as we've stated before, in order to have health, health is not merely the absence of disease, but requires several factors. And these are three of the factors that we've outlined in our previous sessions to define what health is. In the next video, we're going to briefly discuss, or the author in that video will briefly discuss, the emergence of the concept of human rights in the global sphere and how that has evolved over time.
Sometimes people ask me, why is law, justice, and human rights have anything to do with public health? And my answer is usually everything. Because if you think about health, you think firstly about your own right to health. And the World Health Organization Constitution, United Nations treaties, constitutions of many countries around the world include the right to health, the right to a safe environment, sometimes the right to clean water or good food. So these are all kind of basic needs that are really critical for a population or an individual to be healthy. And that's the other thing about human rights. Human rights, protect individual liberty, autonomy, freedom from torture, and also anti-discrimination and the right to justice. So if you think about health, the environment, food, water, justice, if you don't have dignity, justice, and health, it's very, very hard to lead the kind of life that is vibrant and wonderful. And so what your mother told you is true. If you've got your health, you've got everything.
It's been an inspiring evolution of human rights over the last 70 years since the Universal Declaration of Human Rights. Human rights law really only becomes a focal point of global health in the aftermath of the Second World War. And drawing on the UN Charter, the Constitution of the World Health Organization, nations would come together in 1948 to declare a common standard of achievement for all people and all nations in this Universal Declaration of Human Rights. Rather than laying out an expansive human right to health, the Universal Declaration of Human Rights focuses on a standard of living adequate for health and well-being. This standard of living for health and well-being would encompass both a state obligation for medical care, but also a focus on a wide range of underlying determinants of health. As these underlying determinants of health would be codified under international law in the aftermath of the Second World War, the Cold War would serve in many ways to hobble the expansive definition of the right to health first laid out in the Universal Declaration. With the 1966 International Covenant on Economic, Social, and Cultural Rights, limiting the right to health to a right to the highest attainable standard of health. In the midst of the Cold War, the United States and the Soviet Union would come at the right to health with very different ideological definitions of what that right to health included. And with the right to health serving as a Soviet basis for for critiques of capitalist inequalities in health, the United States would push back against an expansive definition of the right to health in this International Covenant on Economic, Social, and Cultural Rights. And yet, after this low point in 1966, in the 1970s we see civil society, the global South, nations coming together around a more expansive vision of the right to health, as WHO would be seen to have the normative legitimacy and authority to declare these obligations. We would see in the 1978 Declaration of Alma-Ata a revitalization of the definition of health in the WHO Constitution, a programmatic implementation for realizing that right under national health policy. Although the Declaration of Alma-Ata would never become part of international law, we would see human rights thrive in the 1980s as civil society embraced a rights-based approach to health within the World Health Organization as a way to respond to the expanding HIV/AIDS pandemic. With this foundation of human rights and global health, the end of the Cold War would provide an opportunity for revitalizing obligations under international law. And we would see in 2000 the UN Committee on Economic, Social, and Cultural Rights declaring in General Comment 14 an expansive vision of the right to health that encompasses a wide range of underlying determinants of health, a vision in line with the 1970s WHO Declaration of Alma-Ata, and providing a foundation for considering both individual medical care and a wide range of social, economic, and political determinants of health, laying a foundation under international law for advancing public health into the future.
Here is a schematic of a timeline showing international development of human rights dating from anywhere from 1945 to 2018. And in fact, in 1945, the UN Charter became the first international treaty to recognize human rights, which formed the principal foundation of this new world body. Operating through the UN Economic and Social Council, the UN would make recognitions for the purpose of promoting respect for the observance of human rights and the fundamental freedom for all. In 1946, the WHO Constitution declared for the first time that the enjoyment of the highest attainable standard of health is one of the fundamental rights of every human being, thereby establishing government responsibility to ensure that, quote, a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. However, during the Cold War, historians do not fully agree on the starting and ending of the points, but during the period that's generally considered the span from 1947, as indicated here by this red oval, and ending as during the 1991 with the dissolution of the Soviet Union, was where there was a lot of disagreement in terms of human rights. But as you can see, during this period, there were a lot of significant advancements, including, as previously mentioned in the video that you saw, the Declaration of Alma-Ata in 1978, which was a robust declaration of human rights, although it did not become international law. Other things that did occur was, even though included in the 1987 WHO Global Program on HIV/AIDS, and then after the ending of the Cold War was the World Conference on Human Rights, which started in 1993. Other things that occurred were the International Conference on Population Development, and of course the WHO Framework on Tobacco and Convention on Tobacco Control. All of these significant developments had within them aspects of human rights for health, and attaining health and not only in the mere presence or absence of disease, but also recognizing that other elements of human rights needed to occur. From a historical perspective, the three fundamental elements or three fundamental documents that constitute the foundation for human rights are first the UN Charter, which was 1945 was the first international treaty to recognize human rights. The WHO Constitution, which came after that in 1946, which declared for the first time the enjoyment of the highest attainable standard of health was one of the fundamental human rights of every human being. And UDAR, the UN Declaration of Human Rights in 1948, which basically stated that everyone has the right to a standard of living adequate for the health and well-being of himself and of his family, including food, clothing, housing, medical care, and necessary social service, and the rights of security in the event of unemployment, disability, widowhood, old age, and other lack of livelihood in the circumstances beyond his control. Although the UN body established many documents professing human rights, it did not establish enforcement or implementation mechanisms until 1993 with the Office of the High Commissioner of Human Rights, or the UN Human Rights Office. It was established in 1993 by the UN General Assembly and has regional structure, and the High Commission promotes human rights. It was adopted by 171 countries, and the U.S. has rejoined the Secretariat. It helps empower people, and it also assists governments through its field presence. And its hope is to promote human rights through its research to empower people to obtain their human rights all around the world. As stated in this figure, the Universal Declaration of Human Rights was adopted in 1948, and it has established the modern foundation that has become the cornerstone of global health, central to public health policies, programs, and practice. But it is the implementation of this document that has been troublesome. And it actually has been the implementation process that has been lacking for a long time and has been actually problematic in many ways. In the next several slides, we're going to look at examples of that implementation process, the WHO's role in that implementation process, and I'm going to show a video of a couple of notable individuals talking about that implementation process. When it comes to implementation of human rights, and the United Nations and the WHO has been lax in terms of its implementation. However, the International Health Regulations, or IHR, has been one of its ways that it has started to implement. It has been revised, and this is a screenshot of the third edition of IHR. So it is now more fully being implemented worldwide, and it is this instrument that is helping to implement human rights fully across different countries around the world.
This shift toward implementation is acknowledged for the first time in 2005, with UN Secretary General Kofi Annan standing before the UN Commission on Human Rights and saying that the era of the declaration is over, that we are now beginning an era of implementation. recognizing the ways in which human rights need to be more than paper documents. They need to be realized in the lives of people throughout the world. Following this encapsulation of an era of implementation, Kofi Annan seeks to mainstream human rights across the United Nations system, recognizing the ways in which every part of the United Nations system needs to implement human rights in its policies, its programs, and its practices. And it's this implementation process that is in many ways so unclear. We know what it means to put treaties into law. We know very little about what it means to translate those international legal obligations into policies, programs, and practices that can realize the highest attainable standard of health for people throughout the world.
Governance sounds like a very cumbersome word, but really what it means that national governments have to govern in a way that's efficient and fair. And so governments should follow what Ben and I call principles of good governance. Things like no corruption, transparency, setting clear targets, monitoring those targets, inclusive participation so that you include civil society and other people who are affected, and then ultimately accountability. So these are the hallmarks of good governance, and governments around the world should do that, and we know that many governments don't. They persecute civil society, they violate the freedom of expression and the free press, and they're hardly accountable, and many of them are corrupt. So we need to do a lot at the national level. But also governance is at an international level, because if you think about the United Nations, UNICEF, and of course the World Health Organization, we want them to be governed well, and we want them to be governed by the same principles of good governance that I talked about. And what's really, really important, it focuses on good governance. It has to really make a priority for health and human rights, because those are the two underpinnings of prosperous societies with good well-being. And so good governance at the local level, the national level, and the international level are all critically important for health and human rights. The WHO was the actual first specialized United Nations agency that was formed when the United Nations was formed. And that constitution does two major things, among many others, but one is it dedicates the organization as the global health leader. And it defines health very, very robustly and broadly. And then secondly, it talks about rights and human rights, and particularly the right to health. Now, WHO, to be very, very honest, has not always been a champion of human rights. It's not always been WHO's fault. There have been many powerful countries that have tried to stop WHO from, being a human rights champion. But it is in WHO's DNA. It's in their constitution, and it's critically important. So things like the right to primary care, the right to universal health coverage are all central to the World Health Organization. And now there's a new Director General, Dr. Tedros, who's focusing on human rights and particularly celebrating the fact that WHO can return as a leader of human rights as we celebrate the 70th anniversary of the Universal Declaration of Human Rights. So there's so much optimism and so much to look forward to WHO's leadership in human rights, but we have to hold WHO to account.
From a global perspective, one of the most successful implementation of human rights has been the Framework Convention on Tobacco Control. This framework was negotiated under the auspices of the WHO in 2003 and was enforced in 2005 and adopted by over 40 states and now by 180 different parties. The parties have overseen the implementation to reduce the consumption of tobacco worldwide. Of course, we know the statistics about the consumption of tobacco leading to COPD, premature mortality, etc., and other diseases, including various cancers, including lung cancers, throat cancers across the world. So, this framework has been utilized and had incorporated various aspects of human rights and other rights. So, we've talked about human rights. Now, here's the section we start talking about ethics. Whereas human rights and ethics are both intended to guide or dictate behavior, human rights have legal power. For example, they're mentioned in the WHO Constitution, other constitutions, and have legal standing. They're usually addressed through government or similar levels of system, so they are in legal language. Ethics mainly focus on societal norms or morality, which may or may not reflected in law, and, and is usually addressed through appealing to societies or communities. When we think about ethics versus rights, as we know, as stated in the previous slide, laws or rights are codified in law. Ethics are usually not codified in law, are based on treatment or societal norms. When we think about treatment that are not codified in law, are based on usually how we treat each other. Usually, this is used, or this slide or this image is used as an example of equality. And in this image, it's assumed that everyone will benefit, that with the same support is being given equally. This second image is supposed to contrast with the equality slide to show equity, in which you give different levels of support. So, for example, here, for the shorter person, you give, for example, 2 boxes to let the shorter person see over the fence so they can watch the baseball game. For this uh, person who is not as short as this person, you give 1 box so they can see, and this person, of course, they don't need a box. So this is supposed to contrast uh, in terms of equity. And this slide is supposed to contrast with equality versus everybody has the same level. So everybody is supposed to have an equal shot, but some people don't have a shot in the terms of equality. Whereas equity, you give different individuals a different box given their deficit, and they can have a shot at seeing the baseball game or enjoying the baseball game equally. So many people have critiqued this cartoon or this image as a very simplistic notion of equality versus equity. The first major critique is that in this example, it shows that this sort of simplistic example is that this deficit is inherent within these individuals. So, a shorter person, in terms of these individuals, are inherent within themselves. So, for example, these issues are inherent within themselves. If you look at, for example, the achievement gap within low income communities, the achievement gap is not an inherent problem within those communities, but is an opportunity gap that exists because those communities have not had the same opportunity as other communities. And in fact, it is due to a lack of resources, and those communities have not had the same opportunity as other resources. So when you look at the complexity of the issue, it cannot be summed up in these types of more simplistic depictions of this type of image. And better representation of this image in terms of equality and equity is truly needed. For example, some have proposed that modifying that simplistic image of people standing in boxes is to use a track example. For example, in track, we don't have people start at the same line because we know that in track, there are differences in terms of the length of time. But what you do have is people stand at different time, at different points to have better equity. So this is equality, this is equity. This makes more sense in the track narrative. And this would be a better representation than the box and baseball example. I personally prefer a better conceptualization, which is this, in terms of equality versus equity, which can be found here on the website, which is to understand that when we're talking about equality, if you do community resources, equality basically says the same communities get equal amount of resources. You have one community that's already affluent that has more resources compared to another community. But in equity, of course, the one community that has less resources needs more resources compared to one community that does not have more resources. And this makes better sense in terms of the equity versus equality element, and sort of moves away from the conceptualization of talking about people and talks more about access to resources. Because when we're talking about equality versus equity, we are truly talking about access to resources at the end of the day. So when we talk about resources, we're talking about actually wealth. And when we think about wealth, we can actually use the Gini coefficient or Gini index of wealth to measure actual inequality and measure the wealth gap. The Gini coefficient or the Gini index is a measure of statistical dispersion intended to represent the income inequality or the wealth inequality in a nation or social group. This data is from Credit Suisse from the Research Institute from 2019, and it shows here the different striata showing the different wealth gap. And the top striata, indicated in black, shows significant wealth gap that exists within a nation. So nation here in black has a significant wealth gap between the high earners and the low earners. So for example, a nation like the US and Russia and also Sweden, indicated here in black, has significant wealth gaps between high earners and low earners compared to other nations that exist where data was available and compiled by Credit Suisse. In the next video, or in the next slide, I'm going to actually show a video of how the Gini coefficient is compiled to give you a better understanding of how you can really measure income inequality via the Gini coefficient.
What is Gini coefficient? Household incomes vary from one household to another. The Gini coefficient measures the spread of household incomes across all households. To understand the Gini coefficient, we start with the Lorenz curve. This curve shows the spread of household incomes plotted on a chart. Households are first organized according to their respective household incomes, from the lowest to the highest. A line is drawn through the points where the cumulative proportion of households is plotted against the corresponding cumulative proportion of income. This is the Lorenz curve. If every household has the same income, the Lorenz curve lies along the 45-degree line. This is known as the perfect equality line, where the household incomes of all households are equally distributed. However, if one household has all the income and others have zero income, the Lorenz curve is flat at the horizontal axis before it rises to 100%, where all the income is earned by one household. This is known as the perfect inequality line. How do we calculate the Gini coefficient using the Lorenz curve? Let us call the area between the perfect equality line and the Lorenz curve as area A, and the area under the Lorenz curve as area B. The Gini coefficient is calculated by taking area A divided by the sum of areas A and B. The Gini coefficient varies between the values of 0 and 1. The Gini coefficient is 0 when the Lorenz curve coincides with the perfect equality line, which reflects perfect equality. As the Lorenz curve moves further away from the perfect equality line, the Gini coefficient increases, reflecting greater uneven spread of household incomes and subsequently greater income inequality. The Gini coefficient is 1 when the Lorenz curve coincides with the perfect inequality line, which reflects perfect inequality. The Gini coefficient is used as a measure of income inequality by countries around the world. However, comparing income inequality across countries using Gini coefficients is not straightforward. This is because different countries may use different equivalent scales, household income definitions, and household coverage. What are equivalent scales? Equivalent scales are used to adjust household incomes, allowing us to compare and analyze households with different compositions and sizes. Equivalent scales take into account the needs of a household increase with each additional member, but not proportionally so. For instance, a household with 1 member uses 1 unit of electricity, but another household with 4 members may not necessarily use 4 times as much. There is a variety of equivalent scales, and different countries may use different scales. Examples of equivalent scales include the per household member scale, modified OECD scale, and the square root scale. To explain each of these scales, let us take the example of a household with 4 members, comprising of 2 adults and 2 children, with a total household income of $4,000. When using the per household member scale, the household equivalence value is the number of household members. The equivalized household income is calculated by dividing the total household income by the equivalence value of 4. The equivalized household income is thus $1,000. When using the modified OECD scale, the household equivalence value is calculated by assigning 1 point to the first adult, 0.5 points to each additional adult, and 0.3 points to each child. In our example, the household equivalence value is 2.1, giving us an equivalized household income of $1,905. When using the square root scale, the household equivalence value is the square root of the number of household members. In this example, the equivalence value is 2. The equivalized household income is thus $2,000. Internationally, there is no standard equivalent scale recommended for general use. For more information on the Gini coefficient and the key household income trends in Singapore, visit www.singstat.gov.sg.
We've talked about equity and we've talked about equality. Now we're going to talk about individual versus group in the context of both ethics and public health ethics, basically medical ethics and public health ethics, and in terms of group needs versus the individual needs, and how do we prioritize in terms of what the group needs versus what the individual needs. And this is very relevant in this time and age given the current discussion that's going on around COVID-19 and the recently announced vaccine mandate by President Joe Biden, given the current situation that we have around the Delta variant and now currently 80 million Americans have not been vaccinated, and we have a resurgence of COVID-19. When we think about ethics, both medical ethics and public health ethics, we can think about medical ethics focusing exclusively on the well-being of the individual. That aligns with the Hippocratic Oath in terms of not to harm an individual and comes from that vein in terms of Hippocrates and his own view of treatment and medicine. So it bears on a lot of respect for autonomy, non-malfeasance, etc., principles of justice. When we think about public health ethics, it targets communities as a whole, seeks to benefit entire societies, balance social benefits, etc., against individual rights. Now, in the context of COVID-19, there is a significant debate in terms of individual liberties, justice, and the public good. So what has occurred has been that debate that has been sparked in terms of the individual liberty of that one person versus the entire societal good. And that debate is occurring within the United States. So balancing the individual liberties against the public welfare. And how do we balance the needs of the individual versus the needs of the many? And how do we really move forward? That has been a significant sort of loggerhead in terms of the society, specifically for COVID-19. So when we think about the issues that have occurred around the vaccine hesitancy, that has been one of the main driving factors at this point in terms of vaccine hesitancy at this point. When we think about ethics in terms of medical ethics versus public health ethics, I think there's a lot of debate that is going on within the United States in terms of vaccinations. But within that debate, I think some of the message that's getting lost. But there are very notable individuals that have produced some interesting TED Talks. And one of those interesting TED Talks is here, Healthcare, Is It a Right or a Luxury? I think this is a very interesting TED Talk. And if you have time, I think it's worthwhile to really watch this and see what Dr. Tariq Samir has to say about his perspective on healthcare. And I think it might add just a little bit of insight from his perspective in terms of his viewpoint that can help at least illuminate some questions that you might have. So if we think about some of the issues that could occur within public health takes into consideration the interests of society as a whole, even when that may conflict with individuals and some of the interests of individuals. So in that case, it may be difficult or impossible to identify how individuals could benefit. Thus, it might not be possible to weigh how individuals could benefit, including the costs or the risks or all the risks or even other burdens. And even for some interventions, especially during pandemics, health authorities may invoke the power of the state. For example, mask mandates, specifically as has occurred time and time again to protect the general public. In the case of global public health, the potential could reach across national, cultural, and economic boundaries, add further moral complexity to some of the decisions that are made by public health practitioners in cases in which there are epidemics and pandemics. And these are just some of the potential issues. There are other long issues which are outlined by Welker and Cash. Finally, when we think about considering ethics in public health, we have to think about what are the public health goals for the proposed intervention policy or program. For example, COVID-19 has provided a significant sort of natural experiment because we have had to develop policies on the fly. Many of these policies have never been developed before um, or since, but only within the context of this pandemic. How effective is the intervention in policy at achieving its goals? We have seen that some policies have been very effective, some have not, and some states and locales have had policies that were effective in that they were able to mitigate or slow down their infection rates, while others have not implemented it, or some have implemented it somewhat less effectively, and it has not worked. Um, what are the known or potential burdens of the program? Some programs have been potentially burdensome for others, some have not. Um, how can we how can burdens be minimized? Many programs have been less burdensome to some populations, some have been burdensome to others. Is the program implemented fairly? That fairness issue has been an issue that has really galvanized many people around the country in terms of fairness of implementation. And can the public health benefits and the accompanying burdens be balanced? And that has been a significant issue. And I think that it's ultimately trying to balance those issues, trying to balance those burdens has been a significant issue in terms of what many public health individuals have tried to do around the country, given the evidence that was available at that time. Ultimately, the success or failure of these many programs around the country has resulted in where we're at this point. But I have to say that it has been ultimately significant in terms of the uneven implementation of policies around the country that has led us to the point that we have had a resurgence of COVID-19 within this country. And not because we didn't have the evidence, but it has been the fact that that evidence was not equally applied faithfully around the country. That's the issue.